Everything Surgery Podcast. Surgical Management of Crohn's Disease. Welcome to the Everything Surgery Podcast. In this episode, we examine the surgical management of Crohn's disease, using the 2020 clinical practice guidance from the American Society of Colon and Rectal Surgeons as our framework. Crohn's disease is a chronic inflammatory condition of the gastrointestinal tract that can affect any segment from the mouth to the anus. Its clinical course is often marked by inflammation, fibrosis, stricture formation, fistulizing disease, abscess formation, bleeding, and a risk of dysplasia or malignancy in selected patients. Although medical therapy remains central to treatment, surgery continues to play a critical role when complications arise, when symptoms persist despite treatment, or when structural disease is no longer amenable to medical management. Operative indications: medically refractory disease patients who demonstrate an inadequate response to medical therapy, who develop complications from treatment, or who are unable to adhere to therapy should generally be considered for surgery. The guideline characterizes this as a strong recommendation based on low-quality evidence. Inflammation in patients with severe acute colitis who fail to respond adequately to medical therapy, or who develop signs and symptoms of impending or actual perforation. Surgery should be performed without delay. This too is presented as a strong recommendation based on low-quality evidence. Stricture for short segment, non-inflammatory, symptomatic small bowel or anastomotic strictures. Endoscopic dilation may be an appropriate initial option. However, when a symptomatic small bowel or anastomotic stricture is not amenable to medical therapy or endoscopic dilation, surgery is indicated. In addition, colonic strictures that cannot be adequately evaluated endoscopically should be considered for resection because of the concern for underlying malignancy. These recommendations are framed as strong recommendations, based largely on low-quality evidence. Penetrating disease: when Crohn's disease presents with free perforation, surgical resection of the perforated segment is recommended. In the setting of abscess formation, treatment may begin with antibiotics, with or without drainage, followed by interval elective resection or continued medical therapy depending on the clinical scenario and patient preference. For enteric fistulas that persist despite appropriate medical therapy, surgery should be considered. Overall, the guidance supports a structured but individualized approach to penetrating disease. Hemorrhage in stable patients with gastrointestinal hemorrhage. Evaluation and treatment may proceed through endoscopic techniques or interventional radiology. By contrast, patients who remain unstable despite resuscitative efforts should generally undergo operative exploration. This recommendation is described as strong, although supported by low-quality evidence. Colorectal dysplasia and cancer: for patients with long-standing Crohn's colitis involving at least one-third of the colon or more than one colonic segment, regular endoscopic surveillance is recommended. Visible dysplasia that can be completely excised endoscopically is generally followed with continued surveillance. However, if dysplasia cannot be fully removed endoscopically, if it is present in surrounding flat mucosa, if it is multifocal, or if colorectal adenocarcinoma is diagnosed, total colectomy or total proctocolectomy is usually recommended. Patients with invisible indefinite dysplasia should be referred to an experienced endoscopist for repeat colonoscopy using enhanced imaging, with repeat random biopsies within 3 to 12 months. If invisible low-grade or high-grade dysplasia is detected on surveillance colonoscopy, high-definition colonoscopy with chromondoscopy and repeat random biopsies within 3 to 6 months is recommended. When invisible low-grade or high-grade dysplasia persists on high-definition colonoscopy with chromondoscopy, total colectomy or proctocolectomy is generally advised. In addition, suspicious lesions such as a mass or ulcer should be biopsied, particularly when small bowel or colonic stricturoplasty is under consideration. Site-specific operations: when disease involves the stomach or duodenum and remains symptomatic despite medical therapy. Treatment options include endoscopic dilation, bypass, or stricturoplasty. For disease isolated to the jejunum, ileum, or ileocolon without existing or anticipated short bowel syndrome, clinicians should consider either escalation of medical therapy or resection of the affected bowel, ideally through multidisciplinary decision-making. In the setting of multifocal disease, stricturoplasty should remain part of the operative discussion. For emergency surgery in Crohn's colitis, the procedure of choice is total abdominal colectomy with endoleostomy. In elective surgery for colonic disease with rectal sparing, segmental colectomy may be appropriate for single-segment disease. whereas total colectomy may be preferred for more extensive involvement. For patients undergoing elective surgery for rectal disease, total proctocolectomy with endoleostomy or proctectomy with creation of a colostomy is generally recommended. Restorative proctocolectomy with ileal pouch anal anastomosis may be considered in carefully selected patients without perianal or small bowel disease, while recognizing the increased long-term risk of pouch failure in this population. Preoperative considerations before surgery. Several factors deserve attention. High-dose glucocorticoids increase the risk of postoperative infectious complications, so tapering these agents before surgical intervention is generally encouraged when feasible. Immunomodulators, by contrast, are not typically associated with an increased risk of postoperative infectious complications and usually do not need to be withheld. The influence of preoperative monoclonal antibody therapy remains controversial, but delaying necessary surgery on that basis alone is not generally recommended. Preoperative nutritional support may reduce postoperative morbidity in patients with malnutrition, and smoking cessation may also improve postoperative outcomes. These considerations are especially important in Crohn's disease, where chronic inflammation, poor nutritional status, and ongoing immunosuppression can significantly affect recovery. Operative considerations. A minimally invasive approach should be considered whenever appropriate in Crohn's disease surgery. In patients undergoing ileocolectomy who carry multiple risk factors, a diverting ileostomy should be part of the operative planning. The extent of mesenteric excision during resection remains controversial, and after ileocecal resection, reconstruction with side-to-side, side-to-end, or end-to-end hand-sewn or stapled anastomosis is considered reasonable, depending on surgeon preference and experience. Postoperative considerations. 1. After surgery for Crohn's disease, patients should be considered for medical therapy to treat residual active disease or to maintain disease remission. Grade of recommendation. Strong recommendation based on moderate quality evidence. After surgery, patients should be considered for medical therapy to treat residual active disease or to maintain remission. This reinforces a central theme in Crohn's disease care. Surgery is not a standalone endpoint, but rather one component of a broader longitudinal management strategy that integrates operative judgment with ongoing medical treatment. That brings us to the end of this episode of the Everything Surgery podcast. We hope this discussion has provided a clear and practical overview of the surgical management of Crohn's disease and the key principles that guide operative decision-making. Thank you for listening. If you found this episode helpful, please like, share, and subscribe so that more viewers can join us for future discussions in surgery.